There is a number that has quietly become one of the most misunderstood pieces of medical data in the lives of Americans over the age of 60. It is a number that millions of people check every single morning. A number that determines whether they feel reassured or anxious as they begin their day. A number that they report to their physician at every appointment, that they track in notebooks and smartphone apps, and that they have been told, repeatedly and emphatically, defines the safety of their cardiovascular system, their blood pressure reading. And here is what the emerging science of geriatric cardiology is now telling us with increasing urgency. The way the majority of Americans over 60 are measuring that number, interpreting that number, and most critically, responding to that number, is fundamentally, and in many cases, dangerously, wrong. Not slightly miscalibrated, not a minor technical imprecision, wrong in ways that are directly contributing to a pattern that emergency physicians across this country are documenting with growing alarm. Patients arriving in emergency departments not because their blood pressure was genuinely dangerous, but because they responded incorrectly to a reading that was misunderstood, mistimed, or measured under conditions that made the number medically meaningless. And the most sobering part of this conversation is that these are not careless people. These are not individuals who ignored their health. These are diligent, health-conscious Americans who believed they were doing exactly the right thing. Hello everyone, I am Dr. Core, and welcome back to Dr. Core Health. This channel exists because the most dangerous health mistakes are rarely made out of negligence. They are made out of incomplete information, out of outdated guidance, out of a medical system that often does not have the time to explain the full picture during a 12-minute appointment. Here, we take that time. We go deep. We give you the complete, honest, clinically grounded information that allows you to make genuinely intelligent decisions about your own health. If you are new here, subscribe now, because what we cover today is directly relevant to the daily lives of tens of millions of Americans, and it may fundamentally change how you approach one of the most important health measurements of your life. To understand the blood pressure mistakes that are sending people to emergency rooms, we have to begin at the very foundation, the measurement itself. Most Americans who monitor their blood pressure at home own a digital upper arm cuff. They sit down, wrap the cuff around their arm, press the button, and 30 seconds later they have a number, systolic over diastolic, and they record it, report it, and make clinical decisions based on it. What they are almost never told is that a single blood pressure reading, taken under uncontrolled conditions, is one of the least reliable pieces of medical data the human body can produce. Blood pressure is not a fixed biological constant like your blood type or your height. It is a dynamic, continuously fluctuating physiological variable that changes by the minute, and in some individuals, by significant margins within a single hour. The clinical name for this phenomenon is blood pressure variability. And in the geriatric population, this variability is dramatically more pronounced than in younger adults. Here is why. As we age, the large elastic arteries, particularly the aorta and the major vessels branching from it, gradually lose their natural compliance and elasticity. They become stiffer, less able to absorb and buffer the mechanical surge of each heartbeat. In a young, healthy cardiovascular system, these elastic arteries act as a second pump, absorbing the peak pressure of each cardiac contraction and releasing it smoothly between beats, keeping the pressure wave relatively stable as it travels through the vascular network. In the aging cardiovascular system, this buffering capacity is diminished. The pressure wave travels faster, rebounds more sharply, and creates wider swings between systolic and diastolic readings with each passing decade. This means that an otherwise healthy 68-year-old may genuinely experience blood pressure swings of 20 to 30 millimeters of mercury between a reading taken immediately upon waking and a reading taken 45 minutes later after a calm breakfast. Neither reading is wrong. Neither reading is an error. They are both accurate reflections of a physiologically normal but highly variable system. But if that individual wakes up, checks their pressure, sees a reading of 162/94, panics, takes an extra dose of their blood pressure medication, and then checks again 30 minutes later. They have now stacked a pharmacological intervention on top of a reading that may have naturally resolved on its own. And that is where the emergency room visits begin. Let me walk you through the 5 most common and most clinically consequential blood pressure measurement mistakes made by Americans over 60. Mistake number 1. Measuring immediately after waking. The early morning hours, specifically the window between approximately 6 and 10 in the morning, represent what cardiologists call the morning blood pressure surge. During sleep, blood pressure naturally drops to its lowest point of the day, a phenomenon called nocturnal dipping. As the body begins to wake, a cascade of hormonal events triggers a rapid rise in pressure. Cortisol surges. The sympathetic nervous system activates. Heart rate accelerates. In healthy individuals, this morning surge is a normal physiological event. But in older adults with underlying vascular stiffness, the surge can be pronounced, and measuring blood pressure during this surge produces readings that are consistently higher than the individual's true baseline pressure during normal waking hours. Measuring your blood pressure within 15 minutes of waking, before your first cup of coffee, before your body has had time to stabilize from the physiological stress of transitioning from sleep to wakefulness, is one of the most reliable ways to generate a falsely elevated reading that does not accurately represent your cardiovascular status. Mistake number 2. Measuring after physical activity, emotional stress, or a meal. This sounds obvious, but in practice, it is violated constantly. You finish walking from the bedroom to the kitchen. You check your blood pressure. You have had a frustrating phone call. You check your blood pressure. You have just finished breakfast. You check your blood pressure. Each of these scenarios introduces a specific and measurable physiological disturbance that transiently elevates pressure. Physical movement, even mild, activates the sympathetic nervous system and increases cardiac output. Emotional stress triggers an immediate catecholamine release that constricts peripheral blood vessels and raises systolic pressure within seconds. A meal, particularly one containing sodium or simple carbohydrates, can temporarily shift fluid balance and alter vascular tone. The American Heart Association guidelines for accurate home blood pressure monitoring specify that the individual should have been sitting quietly, without physical activity or emotional distress, for a minimum of 5 full minutes before taking a reading, without conversation, without television or stimulating content, without caffeine for at least 30 minutes prior. These are not bureaucratic formalities. They are the minimum conditions required to generate a reading with any clinical meaning. Mistake number 3. Incorrect cuff positioning and sizing. The blood pressure cuff must be positioned on the upper arm, with the lower edge approximately 1 inch above the antecubital fossa, the crease of the elbow. The cuff bladder must be centered directly over the brachial artery. The arm must be resting on a flat surface at the level of the heart. The back must be supported against a chair. The feet must be flat on the floor, uncrossed. Each deviation from this protocol introduces a measurable error. An arm held below heart level increases the reading by approximately 8 to 10 millimeters of mercury. A cuff that is too small for the arm circumference, one of the most common errors in the overweight senior population, consistently produces falsely elevated readings of 10 to 40 millimeters of mercury above the true value. 10 to 40 millimeters. The difference between a reading of 130 and a reading of 170. The difference between reassurance and panic. The difference between continuing your normal day and driving to an emergency room. Mistake number 4. Taking a single reading and treating it as definitive. A single blood pressure measurement carries enormous statistical uncertainty. Blood pressure fluctuates continuously, and any given reading captures only a single instantaneous snapshot of an endlessly variable process. The current standard of care in geriatric hypertension management recommends taking 2 to 3 readings at each measurement session, separated by 1 to 2 minutes between readings, and averaging the results. The first reading in a session is almost universally the highest, partly due to the anticipatory anxiety of measurement itself, a well-documented phenomenon called the alerting response. Discarding the first reading and averaging the second and third produces a significantly more accurate and clinically relevant value. Mistake number 5. White coat hypertension versus masked hypertension. White coat hypertension refers to the well-documented phenomenon in which blood pressure is consistently elevated in clinical settings, at the physician's office, at a pharmacy kiosk, but normal during routine daily life at home. This pattern affects an estimated 15 to 30% of individuals who are diagnosed with hypertension based on office readings alone. Conversely, masked hypertension describes the opposite pattern, normal office readings with elevated home readings, a pattern associated with significantly increased cardiovascular risk that is frequently missed precisely because the office measurement provides false reassurance. Neither pattern can be reliably identified without a systematic home monitoring protocol, combined with honest and detailed communication with your physician about your complete home readings, not just the readings that seem most representative or most favorable. Now we arrive at the blood pressure mistake that is most directly responsible for the emergency room pattern I described at the beginning of this video: the unsupervised self-adjustment of blood pressure medication in response to a single elevated home reading. This is an extraordinarily common behavior in the American senior population, and it is entirely understandable from a psychological standpoint. You have been told that high blood pressure is dangerous. You have been told that uncontrolled hypertension damages your heart, your kidneys, and your brain. You see a number that seems high. You want to do something. You have medication in your cabinet. You take an extra dose. The clinical consequences of this behavior range from uncomfortable to life-threatening. Blood pressure medications, whether they are calcium channel blockers, ACE inhibitors, angiotensin receptor blockers, beta blockers, or diuretics, are not fast-acting emergency interventions designed to rapidly lower acutely elevated pressure. They are long-acting pharmacological agents calibrated to maintain blood pressure within a target range over hours to days. When you take an additional unscheduled dose of these medications on top of your regular dose, you do not simply push an elevated reading back into the normal range. You initiate a pharmacological cascade that your physician did not prescribe, did not calculate, and did not account for in your medication regimen. And the most dangerous consequence is not that your pressure fails to come down. It is that it comes down too far, too fast. The condition is called acute hypotension, abnormally low blood pressure, and in older adults, particularly those with the arterial stiffness and autonomic nervous system changes associated with aging. Acute hypotension is a medical emergency. When blood pressure drops rapidly below the threshold required to maintain adequate perfusion of the brain, the individual experiences a sudden onset of severe dizziness, profound lightheadedness, and in many cases, syncope, sudden loss of consciousness. In a 65, 70, or 75-year-old, sudden loss of consciousness carries catastrophic fall risk. The consequences of a fall in this population, hip fracture, subdural hematoma, vertebral injury, are among the leading causes of disability and mortality in the senior demographic. And the patients who arrive in emergency rooms after this sequence of events almost universally report the same story. They saw a high reading, they took an extra pill, they stood up from the chair, and the next thing they remember is the floor. To make genuinely intelligent decisions about your blood pressure readings, you need a clear understanding of what actually causes the acute transient elevations that generate the alarming home readings in the first place, because the majority of these spikes are not caused by a dangerous deterioration of cardiovascular control requiring immediate pharmacological intervention. They are caused by entirely identifiable, entirely manageable physiological triggers. The most common trigger in the senior population is acute pain. Any source of pain, a headache, joint discomfort, a gastrointestinal cramp, activates the sympathetic nervous system and produces an immediate, sometimes dramatic rise in blood pressure. Addressing the pain source consistently resolves the pressure elevation without any modification of antihypertensive medication. The second most common trigger is bladder distension. A full bladder activates the same sympathetic pathways as pain. An older adult who wakes in the night with a full bladder and checks their blood pressure before emptying it may see a reading 20 to 30 millimeters higher than their true resting baseline. Emptying the bladder and resting quietly for 10 minutes before remeasuring frequently reveals a completely normal pressure. The third major trigger is dehydration. This seems counterintuitive. Most people associate dehydration with low blood pressure, but in older adults, whose kidneys respond to volume depletion by activating the renin-angiotensin system, a powerful vasoconstricting hormonal cascade. Mild to moderate dehydration frequently produces elevated rather than depressed blood pressure readings. Drinking 16 ounces of water and waiting 20 minutes before remeasuring can normalize a reading that appeared to demand urgent intervention. The fourth trigger is disrupted sleep. A night of poor quality sleep, sleep fragmentation, or undiagnosed sleep apnea, which becomes dramatically more prevalent after age 60, produces measurable sympathetic nervous system activation that persists into the following morning, generating elevated morning readings that have nothing to do with your baseline cardiovascular status and everything to do with the quality of your previous night's sleep. The fifth trigger is temperature and seasonal variation. Blood pressure is consistently higher in winter months than summer months in the general population, a phenomenon driven by cold-induced peripheral vasoconstriction. An older adult who checks their blood pressure after coming in from a cold morning may see a reading 15 to 20 points higher than their reading taken in a warm, indoor environment 30 minutes later. Understanding these triggers does not mean ignoring elevated readings. It means investigating them intelligently before responding to them pharmacologically. So what is the correct clinical protocol when you see an elevated home blood pressure reading? Step 1. Stop. Do not take additional medication. Do not call 911. Do not begin catastrophizing. Step 2. Identify the context of the reading. When did you last eat? When did you last drink water? Have you been physically active in the last 30 minutes? Are you in pain anywhere in your body? Is your bladder full? Did you sleep poorly last night? Are you emotionally stressed about something specific? Step 3. Address the identifiable triggers. Drink water. Empty your bladder. Sit quietly in a supported chair with your feet flat on the floor. Turn off the television. Close your eyes. Breathe slowly and deliberately. 5 seconds inhaling, 5 seconds exhaling for 5 full minutes. Step 4. Remeasure. Following the correct protocol. Cuff properly positioned. Arm at heart level. Back supported. Feet flat. 5 full minutes of quiet rest completed. Take 3 readings separated by 1 minute each. Discard the first. Average the second and third. Step 5. If the averaged reading from the second session remains above 180 systolic or above 120 diastolic, the threshold that the American Heart Association defines as a hypertensive crisis, and you are experiencing any associated symptoms such as severe headache, chest pain, shortness of breath, visual disturbance, or neurological symptoms, that is the appropriate threshold for emergency medical contact. A reading of 155/90 in an otherwise asymptomatic individual who has just come in from the cold and had a poor night's sleep is not a hypertensive crisis. It is an elevated reading in a specific physiological context that requires monitoring, documentation, and a conversation with your physician at your next scheduled appointment, not an emergency room visit or an extra dose of medication. The concept that your physician wants you to understand and that the appointment schedule rarely allows sufficient time to convey completely is that the goal of blood pressure management is not to hit a perfect number on every individual reading. The goal is trajectory, trend, average performance over time. A well-managed blood pressure patient with occasional transient spikes driven by identifiable physiological triggers is fundamentally different from a patient with chronically and consistently elevated readings driven by inadequate pharmacological control. Your home monitoring diary, a systematic log of readings taken under consistent, properly controlled conditions at the same time each day, documented alongside notes about sleep quality, hydration, activity, and any symptoms. is one of the most valuable clinical tools your physician has access to. It transforms your home monitoring from an anxiety-generating daily ritual into a genuine longitudinal data stream that supports intelligent, individualized cardiovascular management. Blood pressure management after 60 is not a simple equation. It is not about seeing a number and reacting to it. It is about understanding what that number means in context. What generated it, what it tells you about the trend of your cardiovascular health over time, and what the appropriate, measured, clinically sound response actually is. The emergency rooms of this country are seeing a preventable pattern. Older adults who are doing everything right, monitoring their blood pressure, taking their medications, paying attention to their health, being sent into a spiral of anxiety, medication self-adjustment, and acute hypotension by a system that never gave them the complete information they needed to interpret what they were measuring. You now have that information. Measure correctly, interpret in context, respond with clinical intelligence rather than immediate fear, document systematically, and bring that documentation to your physician so that your treatment can be adjusted based on real, reliable, longitudinal data rather than a single office reading taken under artificial conditions. Your blood pressure is not your enemy. It is a signal. And like any signal, its value lies entirely in how accurately it is read. I am Dr. Kaur. Thank you for being here today. Subscribe to Dr. Kaur Health for weekly evidence-based senior health education. Share this video with someone you care about who monitors their blood pressure at home, because the information in this video may prevent the very mistake that sends people to the emergency room. Take care of yourself, and I will see you in the next one.